Hello and welcome to the discussion on the blood supply of the central nervous system, which is of great importance due to the metabolic needs of the nervous tissue, right? And you'd remember from your biochemistry that the brain depends on aerobic metabolism, and you do need the oxygen supply to the brain tissue. Right. And from your cardiovascular physiology, you'd also remember that the brain was going to receive close to 17% of your cardiac output, and it's actually going to utilize almost a fifth of the oxygen that is going to be used by the entire body, right? And you'd also need to remember, still from your cardiovascular physiology, that blood flow through the arteries of the central nervous system is kept constant by an autoregulatory process, right? And these are some of the importances of cerebral blood flow. And you'd also need to look at H plus concentration within the blood. For example, if you're going to have an increased H plus concentration, this is going to depress neuronal activity, and it's also going to increase blood flow, right? Then when you're going to have an oxygen deficiency, right? If you look at the figures there, that's what you expect to use per minute. And you're going to have vasodilation and increased blood flow and oxygen transport to the tissue, trying to compensate for the already diminishing values of the oxygen, right? So if you look at the arterial blood supply, getting to the anatomy now, there is going to be something known as the circle of Willis. The circle of Willis is going to be made or composed of branches that are going to be coming from the carotid system and those that are going to be coming from the basilar system. In a nutshell, the basilar system is originating from the vertebral arteries, which you may remember from your thorax anatomy that the vertebral artery was going to originate from the first part of the subclavian artery, and it was going to have four parts. The first part was going to lie in the neck. The second part was going to traverse the foramen transversalia of C6 to C1. It was going to bypass that of C7 because the foramen transversarium is quite small. Right? Then the third part will lie in the suboccipital triangle as it grooves the posterior arc of the atlas, which is your C1 vertebra. Then it's then going to have a fourth part, which is going to pass through the foramen magnum as it gains access to the cranium. Right. Then your internal carotid, you'd best remember it from the common carotids, which were originating from the arc of the aorta on the left side. Then on the right side, I'm sure you must have mentioned that behind the right sternoclavicular joint, you are going to have a brachiocephalic trunk going to divide into a right subclavian artery and the right common carotids. The common carotids will then gain access to the neck, where you can actually compress them against this anterior tubercle of the transverse process of C6, your Chassaigne neck tubercle. And these common carotids were going to bifurcate at the level of C4 into an external carotid and an internal carotid. The external carotid was going to be the true artery of the face and structured within the head and neck, whereas the internal carotid was going to pass into the cranium, and you're going to see it in front of the middle ear in company of a sympathetic nerve plexus that was eventually going to form the deep petrosal nerve. And you're also going to see it emerging within the carotid canal, which is going to open on the posterior lateral aspect of the foramen lacerum to gain access to the cranium, right? So in a nutshell, that's basically how we are going to form this circle of Willis. The branches are going to come from the internal carotid, then they're also going to come from the vertebral artery system. So not necessarily saying that the vertebral artery will form the circle of Willis, part of its terminal branches will form the sac of Willis. For example, we're going to have the posterior cerebral artery, this one. Then some authors would like to believe that this basilar artery, the part in the midline there where there is the final bifurcation, is also going to be taking part in formation of the sac of Willis. Then from the internal carotid, you're going to have the anterior cerebrals. You're also going to have the anterior communicating and the posterior communicating vessels there. Right. So this is what we want to look at in greater detail for us to be able to understand the blood supply of the CNS. For now, we are particularly looking at the brain and other subcortical structures. And towards the end, we'll then look at the spinal cord as well as the venous drainage of the brain and the CNS, and to say, right? So there's something known as cerebrovascular disease, which results from arterial occlusion, leading to an formation of an infarct, right? So determinants of infarct, like the size of the infarct, will include the caliber of the occluded artery, whether there is existing anastomosis, so that you may be able to have a collateral circulation, the time that has elapsed before you had complete obstruction, right? And you may also have hypertension and degenerative changes that will lead to cerebral hemorrhage, which is part still of cerebrovascular disease. So this is a nice cut picture that is showing us the internal carotid, right? And I'll skip it. Then we'll look at here. So this is the common carotid. Notice how it's going to bifurcate into external carotid, and we can already see the very first branch of the external carotid there is superior thyroid artery. Then this is the internal carotid, right? And it's traversing all the way there. Then it's going to gain access to the cranium, the way I've described it. Right? So if you look at the carotid system, right? If you look at the carotid system, before we get to those branches, the hypophysial, I'll take you back here. If you look at this system, right? The carotid artery, whilst in the carotid canal, remember we said it was then going to open onto the posterior aspect of the foramen lacerum. And it enters the midocranial fossa right beside the dorsum scelli of your sphenoid bone. Right. Then it's going to run forward in the cavernous sinus. Right. So you'd expect your carotid artery to be found within the cavernous sinus. Right. So right before its bifurcation into its terminal branches, you're going to have arteries known as the hypophysial arteries. The posterior hypophysial arteries will supply the posterior lobe of the pituitary gland, which per se, is going to secrete oxytocin and vasopressin that would have been made in the hypothalamus by the paraventricular nuclei and the supraoptic nuclei. And they're going to be stored in the region of the median eminence in structures known as herring bodies. Then they were going to be released via these arteries not via these arteries, but they're going to be released through a neural pathway to the posterior lobe of the pituitary gland, which then secretes them. So it doesn't necessarily synthesize them, right? Then the anterior arteries will supply the median eminence, and they break into capillaries that drain into a small hypophysial portal vein, right? For capillaries in the anterior lobe, right? So that's how the releasing factors that are going to be coming from the hypothalamus gain access to the anterior lobe of the pituitary gland. your adenohypophysis. So you do have gonadotropin releasing hormone. You also have inhibitory ones like dopamine and somatostatin. You have thyrotropin releasing hormone, which is stimulatory, growth hormone releasing hormone. So to mention a few. Right. Then there's going to be the ophthalmic artery, also coming from the internal carotid. This is one of the branches that are given off immediately after your internal carotid artery enters the subarachnoid space. Right. The ophthalmic artery, if you remember your head and neck, it was going to pass through the optic foramen together with the optic nerve. Remember, it was actually going to be inferolateral. And it was going to gain access to the orbit, and it would supply the following structures. It would supply the eye itself via the central artery of the retina. It would supply other orbital contents. It would also supply the scalp. Remember, it was going to give you the supratrochlear and the supraorbital arteries, if you remember the scalp. It was also going to supply ethmoidal sinuses via the anterior and posterior ethmoidal arteries. It was also going to supply the frontal air sinuses. Right. Then there's the posterior communicating artery. The posterior communicating artery is rather slender, right? And it arises from the internal carotid closer to its bifurcation there, right? And it runs backward to join these arteries known as the posterior cerebral arteries, which are terminal branches of the basilar artery. Right? And they also help in forming the circle of Willis. Right? These posterior communicating arteries will give you some arteries known as posteromedial central arteries, which I'll show in a subsequent slide. So just remember that they do take part in the formation of the circle of Willis, and they are actually branches coming from the internal carotid, not the posterior cerebral there. Then there is the anterior choroidal artery. This artery is a wide distribution. It passes along the optic tract and choroid fissure. And by so doing, it's also going to supply the optic tract. Right? But it's actually going to be running along the medial edge of the temporal lobes. Right? So it supplies the optic tract, supplies the uncus, supplies the amygdala, supplies the hippocampus, the globus pallidus, which is basically part of the basal nuclei. Also supplies the lateral geniculate body, which from your vision, you remember, that's where the optic tracts are going to dock. And you also give blood supply to the ventral part of the internal capsule. Right. Then in other cases, it may supply the subthalamus, which you remember from your basal nuclei, a lesion to which will result in hemipalismus if it's unilateral. Also supplies the ventral part of the thalamus and the rostral part of the midbrain. Right. Then its terminal branches will supply the choroid plexus, and it will end by anastomosing with branches that are going to be coming from the posterior choroidal artery. Right. So anterior choroidal artery has a very large distribution. And if you look at that anterior choroidal artery, if you're going to have occlusion of an anterior choroidal artery may be asymptomatic, but due to its wide distribution, there may be slight effects. The reason why you may not see the symptoms is that it does have an anastomosis with the posterior choroidal artery. Right. Symptoms will include contralateral homonymous hemianopia due to the fact that you have included the optic tract and the lateral geniculate body as part of that distribution of this anterior choroidal artery. Right. Then occlusion of the internal carotid will in almost all cases lead to ipsilateral blindness, because that's where the ophthalmic artery will come from, and the ophthalmic artery will give you the central artery of the retina, which travels within the optic nerve. And by now, after having done head and neck, you'd appreciate that that will lead to blindness. Then we'll then look at the midcerebral anatomy. Right. So one of the terminal branches of the internal carotid will be this midcerebral artery, and it's the larger terminal branch. From, if you look at it here, it's the larger, more terminal, and the larger, more direct continuation of the artery. Right. This artery is going to run deep, and the lateral fissure. Remember the lateral sylvian fissure that was actually going to separate the temporal lobes from the frontal lobes, right? And this midcerebral artery, if you look at it, it's going to give you central arteries, right, that are going to be more proximal. So you have lenticular striate arteries here. Then it's also going to give you other branches that will be going to the motor and the sensory areas minus the lower limbs. So the midcerebral arteries will actually supply a very large area of the cortex and other subcortical structures. But if you look at the cortex, it will supply the lateral surfaces, right? Remember the homunculus for the lower limbs were actually on the medial surface of the hemispheres. That is why we're excluding the lower limbs in this midcerebral artery distribution. So if you then have a stroke, that is as a result of your midcerebral artery occlusion, it will not include the lower limbs. Then part of its distribution will go to the frontal eye fields, which by now you remember they're responsible for the voluntary control of the saccades. Those that are going to be in the occipital would control the involuntary. Then other structures supplied by the midcerebral artery, we've already talked about the primary and the premotor cortex, the primary somatosensory area as well. Those that are going to be concerned with language, that are also on the lateral hemispheres, as well as the geniculocalcarine tract, which is part of the visual system. Then if you look at the other terminal branch, which is the smaller one, it's the anterior cerebral artery. Right. And the two anterior cerebral arteries are going to be joined in the midline by what is known as an anterior communicating artery. Right. Then this anterior cerebral artery gives you a very important branch known as the recurrent artery of Eubner. This recurrent artery of Eubner will actually be the artery that you find perforating the anterior perforated substance for it to give blood supply to the head of the chordate nucleus, which is here. The head of the chordate, remember the chordate was going to be part of the basal ganglia, and it's actually going to be part of the striatum, which essentially is the input to the basal ganglia. Right. It also gives blood supply to the adjacent part of the putamen and the anterior limb and the genu of the internal capsule. All of these are going to be supplied by that recurrent artery of Eubner, which is coming from the anterior cerebral artery. If you use older text, it's referred to as the medial striate artery. Right. Then this artery will continue along the upper surface of the corpus callosum as the pericallosal artery, and it will also give a very large branch known as the callosal marginal artery. If you look at the medial part of the hemispheres within that longitudinal fissure. So this anterior cerebral artery will mainly focus on the medial parts of the hemispheres and a very small part or a very small strip on the upper surfaces of the lateral hemispheres onto which the midcerebral doesn't reach. Then I've talked about internal carotid occlusion. You may have formation of aneurysms. An aneurysm is a dilatation in a vessel due to weakness in the wall. So you talk of Berry aneurysms, you talk of Charcot-Bouchard aneurysms. Then you may also have occlusions of the medial cerebral and the anterior cerebral. Right? So an occlusion of the medial cerebral will result in contralateral paralysis, which is most noticeable in the upper body, as well as deficits in the sensory side of things. But however, your lower limbs will be spared to some extent. Then you may have hemianopia due to the geniculocalcarine tracts being involved. Right. Then most importantly, if you have a unilateral occlusion, you don't impair hearing, right? Because of bilateral cortical projection from the organ of Corti, something that we described in the auditory system video, right? Then if you look at anterior cerebral arterial occlusion, you have paralysis and sensory deficits in the contralateral leg and the perineum. And affected patients sometimes also have urinary incontinence caused by inadequate sensations in the perineum. Because you remember, we say that the anterior cerebral will actually supply the medial part of the hemisphere where you have the homunculus for the lower body. Right? So this is an internal carotid occlusion where you have blindness of the ipsilateral eye and contralateral half of the other eye. Then you may have contralateral hemiplegia, hemianopia, global aphasia, whereby you affect both the Wernicke's and the Broca's area, which were the receptive and the expressive speech areas, respectively. Then you may have sensory abnormalities due to the internal capsule being affected, right? And this is what I was trying to describe. This is a medial cerebral artery occlusion. I've talked about this already. So you can read through the words there. I've talked about anterior cerebral artery occlusion as well. You may also read through the words there, but the deficits for anterior cerebral artery occlusion are mainly in the lower limbs, plus or minus the perineum and the pelvis. Then we'll look at the vertebrobasilar system. When I started, I already told you about the vertebral arteries, how they were going to come from the first part, the subclavian artery, how they were going to pass through the foramen transversalia of the upper 6 cervical vertebra. It was going to skip that of the 7th, which was an atypical cervical vertebra because of a very small foramen transversalia. Then it was going to groove the posterior arc of the atlas and gain access to the cranium via the foramen magnum. But for it to do so, it needs to pierce the posterior atlanto-occipital membrane, and then it enters the subarachnoid space. Right. Then it gives off very small branches before the two vertebral arteries will then unite at the caudal border of the pons to form a basilar artery. Right. And the basilar artery will end as the posterior cerebral arteries there. Right. So let's now look at the branches that are actually given off. Gives off spinal arteries, which include the anterior spinal artery, which comes directly from the vertebral artery. You may have the posterior spinal artery, which will actually be 2 in number. They come from either the vertebral artery or pica, which is posterior inferior cerebellar artery. If you look at the anterior spinal artery, it's a single artery which is in the midline. The two of them will join, and from the left and the right, and they'll actually traverse the anterior median fissure of the spinal cord, where you expect extensions of pia mater into there. Then you may expect radicular arteries that will supply the upper part of the spinal cord as well to reinforce the spinal arteries. Then pica, this is the largest branch of the vertebral artery. It is going to be having an irregular course, which is going to be between the cerebellum and the medulla. And the branches go to the posterior cerebellar hemisphere, the choroid plexus of the fourth ventricle, the inferior vermis, as well as the central nuclei of the cerebellum. If you remember the dentate, the emboliform, the glossus, and the fastigial nuclei. And it also gives very important branches that go to the medulla, which is why it's going to be implicated in Wallenberg syndrome, which is lateral medullary syndrome. Then there is Ica, which is now a branch of the basilar artery. This arises from the caudal end of the basilar artery, and it supplies the cortex of the inferior cerebellum anteriorly, and also the underlying white matter, the central cerebellar nuclei, the upper medulla, as well as the tegmentum of the pons. Right. Then there is a labyrinthine artery, which also comes from the basilar artery. This is the artery that is going to be traversing the internal acoustic meatus together with the facial nerve and the vestibulocochlear nerve as it gains access to the inner ear. This is going to be the blood supply of the inner ear. Then you have pontine arteries, which also arise from the basilar artery, which you divide into two. They're short paramedian pontine arteries, then there are long circumferential pontine arteries. The short paramedian pontine arteries will give blood supply to the listed structures. The long circumferential pontine arteries will also give blood supply to the listed structures. Then there's the superior cerebellar artery, which arises almost closer to the termination of the basilar artery. It will also supply the listed structures, to include the cerebellum from its name, the cerebellar white matter and its central nuclei, the superior cerebellar peduncle, which basically allows for movement of fibers between the midbrain and the cerebellum, and the inferior colliculus of the midbrain, which is implicated in the auditory system. So already you can deduce what happens when you have occlusion of these arteries. Right? Then the terminal branches of the basilar artery and the posterior cerebral arteries. Right? And they're going to be posterior medial central arteries, because they're actually those ones which arise closer to the bifurcation of the basilar. So those are the first ones, and they're also central arteries. Then the posterior cerebral artery will give blood supply to the temporal, the calcarine, and it will also give you the parieto-occipital branches. So this will actually be the artery that will mainly supply the visual cortex. Right. Then it also gives you the posterior choroidal artery closer to the region of the splenium, which we said will anastomose with the anterior choroidal artery, and that anastomosis is quite efficient. Right. Then that I'll skip as well as this. Right. Then a posterior cerebral artery stroke will result in homonymous hemianopia, memory deficits, but you have several visual deficits and lack of depth perception or hallucinations. What I want you to remember is, from your visual system, there may be something known as macular sparing, because the end of the cortex, which represents that, will have a vascular supply. Also, some of the arteries will come from the carotid system, right? Then I've talked about the anastomosis, and this is now a life cycle of Willis. So the cycle of Willis, it's an anastomosis between branches of the carotid and those that are coming from the vertebral. So the branches that are going to be making up the cycle of Willis include anterior cerebral artery, anterior communicating artery, internal carotid artery, posterior cerebral artery, posterior communicating artery, and the basilar artery itself. Right. So those are the listed branches, right? And quite often you may have one of the cerebral arteries, anterior cerebral arteries, being quite small. Right? These are the central arteries that I was describing. I'll skip that. They supply the core of the encephalon, which is basically part of the diencephalon, as well as some of the telencephalic structures of the basal ganglia, which that I mentioned, the recurrent artery of Hübner, which is going to perforate the anterior perforated, the region of the anterior perforated substance. Then I talked about aneurysms, then brainstem vascular lesions, a lateral medullary syndrome. You may also have a medial medullary syndrome. Infarction of the, you may have a Weber's syndrome if you affect the posterior medial central arteries. Then for the pons, you get something called locked-in syndrome, quite fatal. Then this is a bit of the mechanics, which you remember from your cardiovascular physiology. You can read through those words. Then the venous drainage of the brain. You'd find that the brainstem and cerebellum are drained by unnamed veins that go straight into the dural venous sinuses that are adjacent to the posterior cranial fossa. The cerebrum has an external and internal venous system, but ultimately all the veins would drain into the dural venous sinuses. Right. So you're going to have external cerebral veins to include the superior cerebral veins. They're about 8 to 12. Right. And these are actually going to empty into the superior sagittal sinus. So this is your superior sagittal sinus, yeah. Then you have those bridging veins, rupture of which will lead to a subdural hematoma. Then you have what are known as superficial meducerebral veins there. These are in the lateral sulcus and they empty into the cavernous sinus. Right? The cavernous sinus is right there. Right? And you have anastomotic channels that drain these superficial meducerebral veins in other directions. Right? So there is a superior anastomotic vein of Trollard, which is going to open to the superior sagittal sinus. There is one there. Then there is a vein of Labe or Lobe, whichever way you may pronounce it, that is going to drain to the transverse sinus. Since this is superficial, there's going to be a deep meducerebral vein, which also runs deep in that lateral fissure. Right. Then you also have anterior cerebral veins, which are going to unite in the region of the anterior perforated substance to form a vein known as the basal vein, which is this one. The basal vein, or the veins of Rosenthal, right, they empty into the great cerebral vein, which is labeled here. Right. These are just pictures showing us what I have described. So those are the internal cerebral veins. The internal cerebral veins, they come from thalamus-striate vein plus the choroidal veins. So here we can see the thalamus-striate plus the choroidal veins. They then become the internal cerebral vein. So internal cerebral vein is thalamus-striate vein plus choroidal vein, right? Then the internal cerebral veins would then unite to form the great cerebral vein of Galen. The great cerebral vein of Galen will receive the tributaries of those unnamed veins that I mentioned earlier on, right? Then it's going to empty into the straight sinus. Right? So this is what I was describing about the superficial mediocerebral vein. It is anastomotic channels, the veins of Trolad that go to the superior sagittal sinus. Then it is the veins of Lappe, which go to the transverse sinus. Then this is also what I've just described. Then the basal vein will receive veins of the optic tract, the hypothalamus, and the temporal lobe. This may be too voluminous for you guys to remember, but if you do have maybe a passion to follow neuroscience or neurosurgery or neurology, that's when all these things may then become quite essential for you to remember. But just remember the basics. Right. Then those are now notes that I made that are describing what all those veins will be describing. Right. Then I talked about a subdural hemorrhage where the bridging veins are actually affected. That's quite different from an epidural hemorrhage, which is rupture of the meningeal arteries. Then blood supply from the spinal cord, I'll summarize it and say that it receives from 2 posterior spinal arteries and 1 anterior spinal artery. And I've already told you where those arteries are going to come from. The anterior spinal artery will come from the vertebral. The posterior spinal arteries will also come from the vertebral, or in some cases, maybe branches of pica, your posterior inferior cerebellar artery. Then the spinal veins will also follow your arteries. Right? So those spinal veins will be drained by reticular veins, which empty into an epidural venous plexus. And the epidural venous plexus will then drain into an external vertebral plexus through channels that are going to be within the intervertebral foramina, where you expected the spinal nerve to be. Right. Then there is the blood-brain barrier. Right. This allows for certain substances to fail to pass from the capillary bed into the central nervous system tissue. Right. And these are some of the areas that are lacking the blood-brain barrier. They are known as circumventricular organs. You look at the area posterior and the medulla. If you remember the rhomboid fossa on the dorsal aspect of the medulla, you talk about the subphonical organ. You also talk about the neurohypophysis because you need to secrete the vasopressin. You also talk about other structures related to the third ventricle, to include your VLT, the pineal gland, and so forth. So that's just about it. Thank you for watching.